All right, let's jump right into this. Welcome to this clinical level explainer, where we're going to completely dismantle everything you thought you knew about fibromyalgia. For decades, this condition was just surrounded by mystery and, frankly, a lot of clinical misconceptions. But today, we're unpacking Chapter 385 to get right to the core of this really fascinating diagnosis. We'll look at exactly how we identify it now, and more importantly, how we treat it.
To start us off, I want you to just think about this question for a second. Is fibromyalgia a joint disease or is it a brain disorder? Historically, because patients come in reporting that they feel, pain all over, the immediate assumption was always that there had to be something physically wrong with the muscles or the joints, a peripheral disease, right? But modern research has definitively pivoted our focus away from the limbs and directly into the central nervous system. Spoiler alert here, it's the brain.
So here's our roadmap for the explainer today. We're going to hit 6 main points. First, redefining fibromyalgia. Second, the central sensitization model. Third, the evolution of diagnostic criteria. Fourth, the differential diagnosis. Fifth, non-pharmacologic management. And finally, pharmacologic treatment strategies.
Okay, Section 1. Let's start by redefining fibromyalgia and stripping away those old myths. The absolutely crucial takeaway is this new definition. Fibromyalgia is a chronic, widespread musculoskeletal pain syndrome. But here is the real kicker. It's accompanied by severe neuropsychological symptoms, and it's driven primarily by the central nervous system. We actually consider it a chronic, overlapping pain condition now. So while the patient is absolutely experiencing real pain in their tissues, the actual driver, the actual generator of that pain is central. It's not peripheral at all.
Moving to Section 2, let's look at the central sensitization model, which really explains the neuropathophysiology here.
Through psychophysical testing and functional MRIs of fibromyalgia patients, we've seen something pretty incredible. Their brains literally light up in pain-processing regions in response to completely normal, everyday stimuli. Think of it kind of like a faulty car alarm that goes off just because the wind blows. And this happens because of two things. First, the sensory pain signals going up to the brain are amplified. And second, the brain's natural ability to send signals back down to turn off that pain, well, it's impaired. This leads to two major clinical signs: hyperalgesia, which is heavily amplified pain, and allodynia, which is feeling pain from totally innocuous stimuli. The brain is actively maintaining the pain loop.
But the physical pain, that's really only half the story here. The neuropsychological symptoms that come packaged with this central sensitization can honestly sometimes impact a patient's quality of life way more than the pain itself. We're talking about profound, severe fatigue and unrefreshed sleep. There's also significant cognitive dysfunction. Patients often call it fibrofog, which really messes with attention, word retrieval, and short-term memory. Add to that a lifetime prevalence of mood disorders approaching 80%, including severe anxiety and depression. And it's highly comorbid with other central overlapping pain conditions, things like irritable bowel syndrome, chronic fatigue, and chronic headaches.
All right, Section 3. Let's talk about the evolution of diagnostic criteria and how our approach has shifted.
There's been a massive clinical paradigm shift in how we diagnose this. In the past, doctors relied on a physical tender point exam. They'd literally use their thumbnail to exert exactly 4 kilograms of pressure per square meter on 18 very specific musculoskeletal sites. But honestly, if this is a brain disorder, why in the world were we poking muscles to diagnose it, right? Recognizing that huge flaw, the newer 2016 criteria threw out the tender point exam entirely in favor of patient reporting symptoms.
So the 2016 diagnostic criteria shifts the focus completely. Instead of prodding the patient, it actually asks them to map out their generalized pain across their body. And it heavily weighs those neuropsychological factors we were just talking about, like the fatigue, the waking up tired, and the cognitive trouble.
And that brings us to how this actually builds into our modern diagnostic metrics. We now use 2 main scores. The Widespread Pain Index, or WPI, tracks the number of body regions where the patient has felt pain over the last week. Then there's the Symptom Severity Score, or SSS, which quantifies the severity of their fatigue, sleep issues, and cognitive dysfunction. A diagnosis is made when a patient meets specific numerical thresholds combining those 2 scores, and, crucially, those symptoms must have been present at a similar level for at least 3 months. I mean, you can see how this is a far more accurate way to capture a chronic, overlapping central pain condition than just pressing a thumb into a shoulder muscle.
Now on to Section 4, the differential diagnosis. How do we distinguish the mimics?
Because the symptoms of fibromyalgia are so incredibly broad, the differential diagnosis is huge. It's helpful to bucket these mimics into clear categories so we avoid cognitive overload. First, we have inflammatory diseases, things like rheumatoid arthritis, lupus, or polymyalgia rheumatica. Then, non-inflammatory issues like your standard degenerative spine disease or localized myofascial pain. We also have to be on high alert for endocrine and infectious mimics. Things like hypothyroidism, hepatitis C, HIV, and Lyme disease can all present with widespread body aches and fatigue. And finally, psychiatric and neurologic conditions like major depressive disorder or multiple sclerosis absolutely need to be considered.
So an absolutely vital point to remember here is that in pure fibromyalgia, routine laboratory tests are going to be completely normal. We don't have a blood test for fibromyalgia yet. Therefore, when we run routine testing, like an ESR or CRP looking for inflammation, a CBC or a TSH for thyroid function, the goal isn't actually to diagnose the fibromyalgia. The goal is strictly to rule out all those mimics we just looked at. And a quick note on radiographic testing like MRIs, they should be used very, very sparingly unless there are specific red flags for inflammatory spine disease. We really want to avoid unnecessary testing and the inpatient anxiety that comes with it.
Section 5. Let's pivot to treatment, starting with the absolute foundation, non-pharmacologic management.
Believe it or not, the absolute most effective strategy for managing fibromyalgia isn't found in a pill bottle. It's physical conditioning. But you have to do it systematically. Step 1 is patient education. You have to sit down and explain the central mechanisms of this disease so they actually understand why they hurt. And you must set the expectation that the clinical goal is improving function, not achieving zero pain. Step 2 is starting extremely slow. We're talking low-level aerobic or supervised water-based exercise. If they push too hard too fast, that central sensation will flare up big time. Step 3 is a slow, consistent advancement into physical conditioning and strength training. And I should mention, additional therapies like cognitive behavioral therapy to reduce illness behaviors, TENS units, yoga, and Tai Chi are also incredibly helpful alongside this.
Finally, Section 6, Pharmacologic Treatment Strategies. How do we target the central nervous system?
When it comes to meds, we want to use single agents that treat multiple symptom domains at once by specifically targeting either the afferent or the descending pain pathways. So, for example, if a patient is primarily struggling with pain and really severe sleep disturbance, a tricyclic antidepressant like amitriptyline, taken at bedtime, or an alpha-2 delta ligand like pregabalin or gabapentin is fantastic. Why? Because they both reduce pain transmission and promote sleep. On the other hand, if their pain is heavily coupled with severe anxiety or depression, SNRIs like duloxetine or milnacipran are usually the best first choice because they offer analgesic, anxiolytic, and antidepressant effects all in one swing.
Now, what is incredibly important, and I really cannot stress this enough based on the clinical literature, is this. Strong opioids must be strictly avoided. Full stop. They have absolutely no demonstrated efficacy in treating fibromyalgia. Furthermore, they carry a high risk of adverse side effects that could severely damage a patient's functional recovery, and they can actually worsen the central pain symptoms over time. It is a total dead end for this specific condition.
Okay, we've covered a tremendous amount of ground today, completely rethinking fibromyalgia, from a mysterious joint ache to a clearly defined central nervous system sensitization disorder. But I want to leave you with this final, somewhat provocative thought. As we continue to map the specific genetic vulnerabilities and these shared neurobiological pathways of fibromyalgia, we're realizing it shares a fundamental base with irritable bowel syndrome, chronic fatigue, and even mood disorders. So, how might our evolving understanding of these shared pathways fundamentally change how we treat all chronic overlapping pain conditions in the future? Is it possible that we might one day have a single targeted therapy that addresses all of them at once? It's a truly fascinating frontier in medicine right now. Thank you so much for joining me for this explainer, and as always, keep questioning what you think you know.